I'll be glad to. So this is the project, where we try to develop a new modified interleukin-2. We know that interleukin-2 has been approved and used for many, many years in a high-dose form, in its natural form, to cure patients with melanoma and kidney cancer. However, it had a lot of side effects, and we could not give it to patients in a clinic. We had to give it in an ICU-like setting. So this is the background. So over the years, people tried to develop modified molecules which would be able to be given in an outpatient setting and yet still have the activity against the tumors, and maybe not just those I named, but others. That was really difficult. We had some failures with NKTR214, with the Syntorx project. However, it looks like the new wave of these modified cytokines is more promising. WTX-124 is actually a native interleukin-2 molecule which has been cleverly connected to the protein domain to make it more stable, so you can give it intravenously and it will have a longer half-life, as well as it has a masking domain which prevents it from being active in the bloodstream, i.e. lowering its side effects. When it enters the tumor, it will use the tumor-specific proteases to cleave off that masking domain, and now a native interleukin-2 is where you need it, which is in the tumor, not in the bloodstream, and it's doing its job of activating T cells as well as NK cells. We have data showing that it has a great pharmacokinetics, linear. The more you give, the better the doses are, the levels are, and we have seen responses to single agent which have not been seen before with either the NKTR214 or other similar approaches. We had responses in melanoma patients, heavily pretreated, refractory to both PD-1, CTLA-4. We also had responses in squamous-cell skin cancers after PD-1 progression, as well as esophageal cancer, which is one of the difficult cancers to treat. We are really excited about that, and we are now selecting the dose 18 micrograms to go forward in expansion cohorts, for refractory melanoma, refractory renal cell, refractory squamous cell, and possibly others. And we are also combining, this drug with Pembrolizumab as an anti, PD-1 checkpoint.